A very good morning to everybody. Hope you're having a wonderful session in the conference. My name is Dr. Reema Patel, and I'm the Medical Director at Old Bridge Medical Center in New Jersey, USA. Diabetes is a complex chronic condition that requires continuous medical care with multifactorial risk reduction strategies that are beyond glucose control. ADA, which is the American Diabetes Association, publishes standards of care that are updated every year. The notable updates in 2023 are as follows. There is emphasis on supporting a higher weight loss up to 15% because now we have drugs that promote a significant degree of weight loss, which we'll talk about in the future slides. There are new hypertension diagnosis cutoffs, where the cutoff is really defined as diastolic blood pressure of more than equal 80 and systolic blood pressure more than and equal to 130. There is an expanded role of SGLT2 inhibitors used in HFrEF and HFpEF patients, meaning heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. There is also a role of finerenone, which we'll talk about a little bit later, in individuals with diabetes and CKD patients with albuminuria. And there are new lipid management guidelines that suggest lower LDL goals, which we'll talk in detail a little bit later as well. The management plan in diabetes needs to take into account multiple factors. It includes patients' age, their school and work schedule, their eating patterns, physical activity, cultural factors, cost and insurance definitely play a very big role. Literacy, especially mathematical literacy and numeracy, are very important, especially when we are talking about patients who have insulin pump and are calculating the amount of carbohydrates and insulin that they are taking. Their comorbidities play a very big role, and of course, patient preference. In terms of comorbidities as a clinician, it is very important when we choose anti-diabetes therapy for a patient to see what comorbidities they have to help us decide what is the best therapy for patients. Especially we are talking about patients with ASCVD, which is atherosclerotic cardiovascular disease, CKD, the risk of hypoglycemia, assessment of retinopathy and neuropathy. We do know that semaglutide, both the subcutaneous as well as the oral, known as the Ozempic and Rybelsus respectively, do increase the risk of retinopathy. So all of these factors are taken into account when we select anti-diabetes therapy for patients. Goal or target in general is an A1C of less than 7% and a fasting blood sugar of between 80 to 130 milligrams per deciliter and a postprandial of less than 180. But as we all know, the goal is individualized for every patient. With the significant and very common use of CGM, which is continuous glucose monitor, we now also have defined the target time and range, which we target for all non-pregnant adults to be more than 70%. But we also want hypoglycemia rates to be less than 4% and severe hypoglycemia defined as blood sugar of less than 54 milligram per deciliter to be less than 1%. This is a typical recording of a continuous glucose monitor. We see that quite often in our clinical practice. It helps us decide where the patient is having trouble. We see their blood sugar trend over 24 hours. We have a glucose marker. We have their target range, and that really helps us define where the problem is and how to help the patients and what dosages of medication need to be adjusted. Now, in terms of pharmacological therapy for type 1 diabetes, most patients are treated and should be treated with MDIs or multiple daily injections with basal and bolus insulin, or with CSII, which is continuous subcutaneous insulin infusion in terms of insulin pump. Now, with the advent of newer insulin pumps like Omnipod 5 and T-Slim and Medtronic, we have what we call as a closed loop technology or a control IQ technology, where the amount of basal is really adjusted based on the sensor data. And this really is called as automated insulin delivery, which has really changed the way we treat patients, especially with type 1 diabetes. And since type 1 diabetes really depends on, is really dependent on the mealtime and physical activity, patients should receive education on how to match their mealtime insulin doses to the carbohydrate, protein, and fat content, and also anticipated physical activity. Now, the non-insulin treatment for type 1 diabetes, pramlintide, has been studied Not very commonly used, but it has been studied and has been actually approved. Metformin has been studied. There is a small A1C reduction, also reduction in weight and lipids. Although here it says that it did not improve A1C, I actually do use it in my clinical practice, especially in my patients who I do feel have significant insulin resistance. GLP-1 receptor agonists has been studied. Liraglutide 1.8 milligrams does show a reduction in A1C, body weight, and also insulin dosages. Again, it's an off-label use, but I personally use it in my clinical practice as well. I use semaglutide as well. SGLT2 inhibitors also have been studied. They do improve A1C, body weight, as well as blood pressure. But again, just remember, there is a significant risk of DKA, especially euglycemic DKA, because with the use of SGLT2 in type 1 diabetes, the blood sugars will improve, the insulin dosages may reduce, and hence there is a risk, especially of euglycemic DKA as well. So again, the risk versus benefit should be evaluated when deciding other therapies besides insulin therapy for type 1 diabetes. In terms of surgical treatment for type 1 diabetes, pancreatic and islet cell transplant can normalize glucose levels and mitigate microvascular complications. However, because of the transplant, patients require lifelong immunosuppression to prevent islet cell destruction. So again, this should be reserved in patients who are undergoing simultaneous renal transplant, or patients who are having recurrent ketoacidosis or severe hypoglycemia despite trying to optimize their medical therapy. Pharmacological treatment for type 2 diabetes is much more wide. GLP-1 receptor agonists are preferred to insulin when possible, because they have greater efficacy, they have more durability of treatment effect, and they also have improvement of weight and a reduction of hypoglycemia benefit. Again, one point that I would like to point out is that in terms of insulin, we have to be aware of over-basalization. Patients come to me with 40, 50, 60 units of basal insulin, and that's really when you should suspect that these patients are over-basalized, because you're really going to end up, particularly with either nighttime or morning hypoglycemias, and you will not be able to fix the postprandial hyperglycemias during the day, which is a problem with patients with diabetes. Again, some clinical considerations: metformin should be continued upon initiation of insulin therapy unless it is contraindicated or not tolerated. And again, insulin should be considered if there is ongoing evidence of catabolism. For example, if there is weight loss, ketosis, or patients are having symptomatic hyperglycemia. Or of course, when there is severe hyperglycemia, for example, blood sugars are more than 300 or an A1C is more than 10%. Again, as the glucotoxicity resolves, it is mostly possible to simplify the patient's regimen and change to non-insulin agents. Again, remember, based on the comorbidities, especially ASCVD, CKD, heart failure, SGLT2 inhibitor therapy, as well as GLP-1 agonist therapy is indicated for patients. And the most important thing is these therapies are indicated independent of what the baseline A1C is and what their target A1C is, and independent even of whether the patients are using metformin or not. So these therapies are indicated even if the patient's A1C is 6.2% for additional benefit of the reduction of the other comorbidities. Again, if the A1C is above target, choice of basal insulin should be really based on patient considerations, initiated, titrated as needed, and if there is hypoglycemia, we should be reducing it. In some cases, intensifying therapy is indicated. We usually start with addition of one a prandial insulin. Usually it is dinner for most patients, or a meal that is causing the maximum postprandial excursion. And sometimes if A1C is still beyond target, then stepwise addition injections of additional prandial insulin is necessary. I would like to talk about Afrezza, which is an inhaled insulin. It is the only inhaled insulin that is available, and studies do show that there is faster onset and shorter duration. So as we call it, faster in and faster out. And it did show reduction in A1C and weight reduction over 24 weeks of clinical trial. And it is most active between 35 to 45 minutes, and it stops lowering blood sugars within 1.5 to 3 hours. However, it can cause a decline in lung function, especially FEV1. So it is contraindicated in patients with chronic lung disease, such as asthma or COPD. And it is not recommended for patients who are smoking or who have recently stopped smoking. When patients are prescribed Afrezza, it is important to do spirometry and FEV1 testing before as well as during therapy. Again, if you prescribe patients insulin, glucagon is really a reflex. I prescribe all my patients glucagon, whether it is injectable or inhaled. We'll talk about the inhaled insulin in just a second. Again, Baqsimi, which is basically the inhalation glucagon, works as well as the injectable glucagon. I actually prescribe this a lot. And this can be used whether the patient is, when the patient is either about to pass out or actually passed out. It does not require patient cooperation, so it can be given. The patient does not need to take a deep breath. It's just a spray, and it should be given even if the patient is having nasal congestion or is using decongestants. One clinical pearl that, again, very common is that metformin is associated with B12 deficiency, especially in patients who are vegetarian, which we see in the Indian population a lot. So it should be tested and treated, especially because B12 deficiency can cause neuropathy as well. This is the list for the various non-insulin therapy for diabetes type 2. Again, we are living in this world in 2023 where we have so many options to give patients a non-insulin therapy for type 2 diabetes. I could spend about 20 minutes just on this slide, but again, this slide is actually from ADA, which is the American Diabetes Association. Very, very important, and again, a very detailed slide. It really guides us as to what needs to be done, particularly in relation to the comorbidities when patients have other comorbidities, on how to choose it. But mainly if patients have ASCVD, heart failure, or CKD, SGLT2 inhibitors, as well as GLP-1 agonist with proven benefits should be used. Again, Toujeo, which is the concentrated Lantus, and Tresiba, these are the newer insulin analogs that we see. Toujeo versus Tresiba, there was similar glycemic control as well as hypoglycemia that were observed in patients with both type 1 as well as type 2 diabetes. Again, however, the dose of Tresiba, and I see this in my practice as well, that the dose of Tresiba that takes to obtain euglycemia or normal glycemia is actually less compared to Toujeo. And this is what they saw in the clinical trials as well, that the mean daily basal insulin dose on day 1 as well as by week 24 was higher with Toujeo. So it required more dose of Toujeo compared to Tresiba to maintain the same glucose level. And since you're using more glucose, the weight gain in the Toujeo group was more compared to Tresiba. And again, similar findings are seen in my clinical practice as well. At this time, majority of my patients are either on Toujeo, or Tresiba. Lantus and Levemir is used, but at this point is used much less commonly in my clinical practice. Again, the bright renal subgroup data also suggested that Toujeo delivers greater A1C reduction, and there was comparable risk of hypoglycemia. So it maintained its efficacy even in patients with CKD. Again, similarly, Toujeo versus Tresiba in type 1 diabetes, there was similar glycemic control and hypoglycemia that was seen. Now, Toujeo, which is the concentrated version of Lantus, it comes in Toujeo as well as Toujeo Max. The Toujeo Max is recommended for patients who need at least 20 units of insulin a day. The difference between Toujeo Max and Toujeo is that the Toujeo Max, the maximum dose is 160 units per injection versus 80 units for the Toujeo SoloStar. And Toujeo Max, you can change the dose by 2 units increment versus 1 unit increment with the regular Toujeo. And the Toujeo Max actually can hold up to 900 units compared to 450 units in Toujeo SoloStar. The Tresiba comes in 3 versions, the Tresiba U100, Tresiba U200, as well as the Tresiba vial. The Tresiba vial in the United States only comes in the Tresiba U100. The U100 pen contains 300 units and U200 contains 600 units. So I usually use the Tresiba U200 in patients who have higher daily insulin requirements. Again, U500 insulin is a very, very concentrated and a very powerful insulin. It is 5 times more concentrated than the standard U100 insulin. And again, when insulin is concentrated, it takes less liquid and it will help you reduce your blood sugar level, but you can inject 80% less liquid and you will still get the dose that you need. The U500 is usually prescribed either BID or TID, meaning either twice a day or 3 times a day. The U500 is available either in a form of a pen or in the form of a vial. When using a vial, the syringe that is used for the U500 is different compared to the regular syringes that is used, because if the patients use the regular syringes, they can actually miscalculate the dose. So it is very important to educate the patient to use the U500 syringe. However, nowadays, as long as insurance covers, I actually prefer to use the U500 pen because it is much more convenient and there is no dose conversion that the patient has to do. So it is much more convenient for the patient. Ozempic, which is the subcutaneous version of the semaglutide, came out a couple of years ago and has really changed the face of diabetes in the United States. And it is really a very potent agent in terms of diabetes control. As you can see that the studies on the left side comparing Trulicity, which is dulaglutide 0.75 and 1.5, the A1C reduction was 1.4 and 1.6%. Now the subcutaneous Ozempic comes in multiple doses, 0.25, 0.5, 1, and now it is even available in the 2 milligram dose. The slides on the graph on the right side shows Sustain Forte, which was the comparison between Ozempic 1 milligrams versus Ozempic 2 milligrams. And there was a further reduction. The A1C reduction was actually 2.1% with the 2 milligram Ozempic dose. Again, really very powerful agent, once a week subcutaneous injection, very convenient. Of course, it is a GLP-1, so it is associated with GI side effects, but when titrated the right way, and I give instructions to the patients about how to mitigate the side effects, I usually tell the patients to listen to your brain and to listen to your stomach. That's really how I put it, that if your brain and your stomach are telling you to stop eating, you should stop eating because it does improve satiety. It does slow down the stomach transit. So that's why patients do feel full. I also advise them to maintain enough hydration. I tell them to go for walks, especially after dinner, because dinner is the heaviest meal for most patients. And I also tell them to avoid constipation because constipation is one of the side effects of this as well. To eat slow, to stop eating when you feel full. And these are really the things that I tell the patients. And again, when titrated the right way, because each dose subcutaneously is titrated for a month, most patients can get to the high dose without any GI side effects. Again, Ozempic and weight loss, we do know Ozempic causes weight loss. I see that in clinical practice as well. There's around 9 pound to 12.8 pound reduction. And again, with the 2 milligram dose, we see a further reduction in weight, 14.1 pounds. I do see that it's a pretty significant weight loss. And again, we do see that. So again, significant A1C reduction, significant weight loss. Now, Mounjaro, which is tirzepatide, is really the new kid on the block. It was recently approved. This is one of the newest agents for diabetes in the United States that was approved. And this is the first and only approved agent that activates GIP as well as GLP-1 receptors. And it comes in multiple doses, starts with 2.5 and goes up to 15 milligrams. And this demonstrated superior A1C reduction when compared to Ozempic 1 milligram. They did not have studies comparing Ozempic 2 milligrams. But again, this is a significant A1C reduction. You can see that Mounjaro at the highest dose of 15 milligrams actually causes an A1C reduction of 2.3%, which is very, very significant. Mounjaro 5 milligrams, which is the lowest therapeutic dose, caused an A1C reduction of 2%, which was actually slightly more when compared to the Ozempic 1 milligram dose. And again, in terms of weight loss, we do see a significant amount of weight loss as well, anywhere from 17 pounds to 25 pounds, more potent than Ozempic 1 milligrams, seeing that currently in the clinical practice as well. So again, a very, very potent agent, both for A1C reduction as well as weight loss. to talk a little bit about finerenone, which is marketed under the brand name of Kerendia, also relatively new in the United States. It is a non-steroidal class of mineralocorticoid receptor agonist. And there was a study, finerenone in reducing kidney failure and disease progression in diabetic kidney disease, Fidelio DKD, which examined the renal effect and demonstrated significant reduction in diabetic kidney disease progression as well as cardiovascular events in patients who had advanced DKD. The primary endpoint was the onset of kidney failure, a sustained reduction in GFR, or renal death. And the secondary endpoint was the first occurrence of cardiovascular death or non-fatal cardiovascular events. It comes in 2 doses, 10 milligram and 20 milligrams. So ADA, which is the American Diabetes Association, actually stated that for patients with CKD and type 2 diabetes who are taking the maximum tolerated doses of ACE inhibitors and or ARBs, recommend the addition of Kerendia to improve cardiovascular outcomes and reduce the risk of CKD progression. Again, this was part of the guidelines that was proposed by the ADA this year. And again, lipids and diabetes, the updated ADA standards of care 2023 stated to use high-intensity statins in individuals aged between 40 to 75 who have one or more ASCVD risk factor. The target was either to bring their LDL cholesterol by 50% of their baseline or to a target of less than 70 milligrams per deciliter, which is quite a robust target. And again, those patients who have established cardiovascular disease, the target LDL is less than 55 milligrams per deciliter. If patients are already on maximum tolerated statins and still not achieving target, then we usually add either ezetimibe or Zetia or a PCSK9 inhibitor. Usually Praluent or Repatha is the one that we add to maximum tolerated statin therapy. And that is all that I have. Thank you so much for your attention and have a good day.